Welcome back to Rad Smart Review, Thoracic Edition. Today we are looking at a topic that, well, it centers around a single word that changes a patient's entire world.
Yeah, that magical word.
Exactly, the word resectable. I mean, imagine you're a patient. You've just been handed this terrifying diagnosis of non-small cell lung cancer, and then the doctor says, good news, it's resectable.
It sounds like a total guarantee, right?
Right. It sounds like, oh, I just go to sleep, the surgeon cuts out the bad part, stitches me up, and I get my life back. Like the hard part is already over.
And that right there is arguably the most dangerous illusion in our entire vocabulary.
It really is a trap, isn't it?
A massive trap. I mean, the moment a clinical team casually labels a stage 2 or stage 3 lung cancer as resectable without doing the actual grueling math to back it up, they're walking that patient straight into a disaster.
Because we all crave that simplicity. We want the tumor to be like, I don't know, a splinter. You see it, you pull it out, and problem solved.
Exactly. But a Roman numeral on a staging chart doesn't tell you if the human chest, which is, incredibly dense and complex, can actually be cleared with perfectly clean microscopic margins.
Right. It's not just about what you can see.
Exactly. And it doesn't tell you if the patient has the physiological lung reserve to even survive losing an entire lung. And it certainly doesn't tell you if the cancer has already seeded these microscopic colonies into the bloodstream.
Which means rushing them to the operating room could be a catastrophic strategic error. And that tension is exactly what our mission is today. We are trying to build a coherent, curative strategy from incomplete information.
Yeah, because we're looking at all these guidelines and trials and trying to figure out how to sequence surgery, systemic therapy, and radiation.
Right, without letting any of those treatments completely sabotage the others. Because if you come in with radiation too early, you might cause irreversible toxicity that prevents a life-saving surgery.
And if you enter too late, you're trying to mop up a disaster that could have been totally prevented. You really have to preserve the battlefield.
Preserve the battlefield. I love that.
Yeah.
Because the sequence you pick on day 1 completely dictates the weapons you have left on day 1,000.
It really is the perfect lens for this, because in stage 2 and 3 non-small cell lung cancer, that battlefield is just incredibly fragile.
Oh, absolutely. The heart, the remaining healthy lung tissue, the esophagus.
The spinal cord. I mean, they all have finite limits to the trauma they can endure, and every single decision you make burns a little bit of that tolerance.
So, to keep our discussion really grounded today, we aren't just going to rattle off abstract rules. We are going to anchor everything to a specific patient.
I like that. Let's walk them through the actual decision points.
Right. So you're sitting at the multidisciplinary tumor board, and this case pops up on the screen. Here are the facts. We got a biopsy-proven non-small cell lung cancer.
Okay, good start.
And thankfully, a brain MRI and systemic imaging show 0 confirmed distant metastatic disease. No obvious spread to the liver, bones, or brain.
That's a relief.
Yeah. But looking at the chest imaging, there's an ipsilateral hilar abnormality. So a swollen area right where the vessels enter the lung on the same side as the tumor.
Right, pretty common.
But here is the critical catch. There is one suspicious ipsilateral mediastinal lymph node. It lit up really brightly on the PT scan.
Oh boy, here we go.
Right. And the pulmonologist chimes in and says, hey, their breathing tests are good, they can tolerate an operation. And the surgeon says, yep, a lobectomy is technically feasible.
And this is usually the exact moment where the tumor board just descends into total chaos.
It really does. Because that one glowing node has not been pathologically confirmed.
Right. No one has put a needle in it yet. It's literally just a bright pixel on a screen.
Exactly. And based on that unverified pixel, you'll hear 4 different specialties pitch 4 completely contradictory treatment pathways.
Oh, absolutely. The surgeon says lung function is good. Let's just go straight to the OR.
The medical oncologist is like, wait, no, neoadjuvant systemic therapy first, then surgery.
Then the radon grabs the mic and says, we need pre-op radiation to sterilize the area.
And some fourth voice suggests we just abandon surgery entirely and do definitive chemoradiation. So if you're listening to this, the actual consult question you have to answer isn't just, should we give radiation?
Yeah, that's way too narrow. The real questions are, what hard facts do we absolutely need before we lock in a sequence? What specific operation are we trying to save?
Right. And what pathological findings down the road actually trigger a mandatory need for radiation?
Because curative intent doesn't just automatically equal surgery. It requires a strategy that attacks visible disease, hunts down invisible disease, and actually respects the patient's physiology.
Yeah, you can do a technically flawless lobectomy, but if your nodal staging was wrong from day one, you didn't cure them. You just gave them a really expensive, painful, futile surgery.
Exactly. So before we pick a drug or like turn on the linear accelerator or lift a scalpel, we have to fix this incomplete workup.
We have to address the staging trap. Staging isn't just paperwork. It's the foundation of survival. So let's talk about the AJCC version 9 rules for lung cancer, because the nuances there totally change how we look at that suspicious node.
Yeah, version 9 is such a great story of increasing precision because historically, any cancer that spread to the mediastinal lymph nodes, those nodes in the center of the chest, was just dumped into one big category, N2.
The dreaded N2.
Right, it was this terrifying monolithic label that usually disqualified people from surgery right out of the gate. It was basically synonymous with stage 3.
But version 9 recognizes that biology isn't a monolith, right?
Exactly. It splits that old N2 category into subgroups based on the volume and location of the disease.
Which is a huge shift. So let's break that down for the listeners, because we have to unlearn the old reflexes. We start with N1 disease, which means the cancer spread to nodes within the lung itself, or the Hiller nodes right at the root of the lung.
Right, still localized to the affected organ.
But when we cross into the mediastinum, we hit these new N2 subdivisions.
Yeah.
First is N2A, which is a single ipsilateral mediastinal or subcarinal station. So just one nodal zone on the same side.
It's just one.
And then N2B describes multiple ipsilateral stations. The cancer has hopped to 2 or more distinct zones in the center of the chest.
And honestly, the clinical gravity of that split is just massive. It shatters the idea that every N2 presentation is some unresectable stage 3 nightmare.
Right, because depending on the primary tumor size, like if it's a small T1 versus a larger T3, a single station N2A can actually fall into stage 2.
Exactly. It behaves much more like localized disease. But that multi-station N2B disease firmly cements them in stage 3 because it reflects a much more aggressive systemic biology.
It tells you how efficiently the tumor is using the lymphatic highways.
Yeah, exactly.
So back to our patient, we have one suspicious mediastinal node on the PET. If it really is just that one node, we might be looking at N2A, which is super favorable for surgery.
But right now, we are just guessing. The PE shows a glowing spot, and it's so tempting to just accept it at face value.
Oh, for sure. Someone will see that bright orange blob and say, well, it's consuming glucose, it's PET-avid, it has to be cancer. Stage them as N2 and let's move on.
Which is practically clinical malpractice, because a P-scan is not pathology. It's a metabolic map, not a cellular diagnosis.
FDG just goes wherever there's high glucose metabolism.
Right. Cancer cells are greedy, so they light up. But you know what else is greedy? Macrophages fighting an infection. Granulomatous disease, a lymph node reacting to a recent pneumonia.
Oh, or histoplasmosis.
Exactly. Even a recent COVID-19 vaccine in the arm can make the axillary and mediastinal nodes light up like a Christmas tree. Inflammatory false positives are just everywhere in the chest.
Okay, let me play devil's advocate for a second. Let's say I'm the surgeon in the room. I might say, look, I have to go into the chest anyway to take out the main tumor. Why delay curative surgery by 2 weeks to schedule a separate biopsy for this one node?
Right, the classic surgeon argument.
Yeah. Let me just take them to the OR, take out the lobe, dissect the nodes while I'm there, and the pathologist can tell us what it is. We get diagnosis and cure in 1 day. If the PD is highly suspicious, why jump through the hoops of a pre-op biopsy?
Because that's like buying a house based purely on a beautifully lit real estate photo without demanding a structural inspection.
Oh, that's a great analogy.
Right. I mean, you would never sign a 30-year mortgage without knowing if the foundation is rotting. So why would you permanently amputate a massive portion of someone's respiratory capacity based on an unverified PT image?
Because if you open the chest, take the lobe out, and then find out that node was actually packed with cancer,
yeah,
you're in trouble.
you've completely missed the window for neoadjuvant systemic therapy. You lost the chance to shrink the disease, you lost the chance to test the biology against the drugs in real time, and you just forced the patient into a highly toxic recovery phase where they probably can't even tolerate the chemo they now desperately need.
Wow, yeah. The
Yeah.
foundation really matters. And that brings us to the efficient biopsy principle, right?
Yes, absolutely. In thoracic oncology, if you have multiple suspicious targets, you don't just biopsy the easiest one to reach. You biopsy the site that establishes the highest possible stage.
So if that glowing node changes them from stage 1 to stage 3, or dictates if they get neoadjuvant drugs, It absolutely must be sampled.
It has to be. And how we sample it is a big deal now, too. We used to rely on mediastinoscopy, making an incision above the sternum and using a rigid scope to physically snip pieces of the nodes out.
Which is a real surgery requiring general anesthesia.
Right. But today, the gold standard is an EBS, an endobronchial ultrasound. The pulmonologist passes a flexible scope down the airway with a tiny ultrasound probe on the tip.
So they can look right through the wall of the trachea to see the nodes.
Exactly. Then they pass a fine needle through the airway wall directly into the node and aspirate cells. It's elegant, minimally invasive, and you can map out the whole mediastinum in one go.
Okay, so let's play that out for our patient. The pulmonologist does the EBUS, nails the single glowing node perfectly, and sends it to pathology. The pathologist says, negative for malignancy, just normal lymphocytes and inflammation.
Oh, boy.
Right. Do we pop the champagne? Can we declare them N2 negative and rush to the OR?
Not so fast. This is where pretest probability is everything. An EBUS is just a needle aspiration. It pulls a tiny thread of cells out of a much larger structure.
So a negative needle doesn't magically erase a highly suspicious clinical picture.
Exactly. Was it a true negative because it's just inflamed? Or a false negative because the needle passed right next to a microscopic nest of cancer cells?
Right. If you have a massive primary tumor and an intensely hot PET node, the pretest probability is super high.
You can't just shrug and assume the EBUS was flawless in that case. You might actually need to escalate to that surgical mediastinoscopy to physically remove the whole node and prove it's benign before you commit to cutting out the lung.
And that right there is the difference between textbook knowledge and clinical mastery. An expert says, I will pathologically confirm this disease, rule out distant spread, and then I'll ask the surgeon to name the exact operation.
Naming the operation is the crucial pivot point. Because once you get the biopsy, everyone rushes to say, okay, let's operate. But doing that without defining the mechanical reality is a disaster.
Right, we have to separate medical operability from anatomic resectability. People conflate those all the time.
Oh, constantly.
So medical operability is just physiological. Can this specific body survive the trauma of anesthesia, major chest surgery, and the permanent loss of lung volume?
Right, so we look at the PFTs, the FEV1, how much air can they blow out, the DLCO, how efficiently do their lungs transfer oxygen. We put them on a treadmill for a cardiac stress test.
Because clamping off a pulmonary artery causes a huge sudden shift in vascular resistance.
Exactly. If someone has severe COPD, history of heart attacks, and uses home oxygen, they could have a tiny, easily reachable stage I tumor, but they are medically inoperable. The surgery would kill them before the cancer ever did.
Yeah. And then you have anatomic resectability, which is the mechanical, spatial side. Can the surgeon physically extract the tumor and all the draining nodes and get an R0 resection?
Meaning completely negative microscopic margins.
Right. And do it without causing catastrophic damage to adjacent organs.
Because you could have a 40-year-old marathon runner who is incredibly medically operable, but if their tumor has grown directly into the wall of the aorta or wrapped around the pulmonary artery or invaded the spine,
it's anatomically unresectable.
Right. A surgeon can't just carve a tumor off the aorta without risking a fetal hemorrhage. You can be fit but unresectable or resectable but unfit.
So for anyone listening trying to survive their first tumor board, I like to use a simple mnemonic here. CORE. You have to establish the CORE before you touch the scalpel.
I love that. Let's break it down.
So C is confirm. Confirm the nodal status pathologically. Don't just trust the PET. O is operability. Assess their physiological fitness. R is resectability. Verify with the surgeon that an R0 margin is anatomically achievable, and E is establish. Establish the exact operation in sequence.
And that E is where the magic happens. The golden rule here is the surgeon must explicitly name the intended operation before anyone gives a single drop of induction chemo or a single gray of radiation.
Right, they can't just vaguely say, we'll do a resection.
Exactly. They have to state, I am planning a lobectomy, or this will require a pneumonectomy.
And why does that matter so much? Like, why does the radiation oncologist or the medical oncologist care exactly what cut the surgeon makes?
Oh, it changes everything. A lobectomy removes one lobe, which most patients can adapt to, but a pneumonectomy removes the entire lung. The physiological devastation is massive, and the 30-day mortality rate just skyrockets.
And for radiation, it's a huge deal.
Right. If they only have one lung left, and you later need to radiate a recurrence, the scatter dose to that single remaining lung could cause fatal radiation pneumonitis. You have zero margin for error.
Which leads right into a massive trap. using induction therapy as a disguise. Say you have a tumor invading a critical structure. It's anatomically unresectable. Someone at tumor board inevitably says, well, let's just hit it with heavy chemo and radiation. Maybe it'll shrink away from the aorta, and then we can take it out.
Ugh, that is such a dangerous strategy. I mean, induction therapy is powerful, sure. It shrinks tumors and clears microscopic disease. But it should never be used as a magical cloak for a tumor that lacks a plausible surgical plan at baseline.
Right, you can't just blindly irradiate an unresectable tumor, wait 2 months, and pray for a surgical miracle.
Exactly, because the fibrotic scar tissue from the radiation makes the surgery incredibly dangerous. The tissues become completely wooden.
You're basically trying to peel concrete off an eggshell.
That's a perfect way to describe it. If the surgeon can't describe a realistic route to an R0 resection on day 1 and define the milestones needed during induction, you should probably abandon the surgical fantasy entirely.
Commit them to definitive, non-surgical chemoradiation instead.
Yes, which is highly effective and completely avoids the massive mortality risk of a desperate, failed operation.
Okay, so let's say the CORE is solid for our patient. The EBUS confirmed the single node is malignant, so we have N2A disease. They're physiologically robust. The tumor is completely separate from central structures, and the surgeon explicitly names a lobectomy.
Okay, perfect. A resectable, node-positive patient.
So now we have to lock in the systemic sequence. How do we sequence the drugs? And the paradigm shift here is that this decision absolutely must happen before the surgery.
Yes. For eligible, resectable, node-positive disease, perioperative systemic therapy is mandatory. It's not an optional add-on if the surgeon feels like it.
You can't just discover you need drugs as a panicked afterthought when the lung is already in a bucket.
Exactly. And to understand why, look at the history. For decades, the standard was surgery first, and if they recovered, we gave adjuvant, post-op, cisplatin-based chemo.
And that was based on the LAZ meta-analysis, right?
Right. It pooled thousands of patients and proved that post-op chemo gave an absolute 5-year overall survival benefit of 5.4%.
I always like to pause on that 5.4% number because to a patient, they hear that and think, wait, you want me to do months of toxic nerve-damaging platinum chemo just for a 5% better chance at 5 years?
I know, it sounds tiny to them. But across a global population, that 5% is tens of thousands of lives. It proves that even when the surgeon gets all the visible cancer, microscopic disease has likely already escaped.
Right. It's a flashing neon sign saying, distant microscopic disease is going to kill this patient. But even though LG's proved we need chemo, the timing has totally shifted. We're moving aggressively toward neoadjuvant therapy.
Yeah, giving it before surgery. And honestly, a lot of that is just logistics and physiology, because trials show neoadjuvant and adjuvant give roughly the same survival benefit, but deliverability is wildly different.
Oh, for sure. Trying to get someone to tolerate cisplatin after their chest was just cracked open and a lung removed.
It's nearly impossible. They're dealing with pain, weight loss, deconditioning. The drop-off rate is massive. But if you give it neoadjuvantly while they're relatively healthy, a much higher percentage actually finish the whole course.
Plus, there's that biological argument. It's like an in vivo stress test.
Exactly. You give the chemo, watch the scans. If the tumor melts away, great, the drugs are working. If it aggressively grows right through the chemo, that's not a failure, that's intelligence.
Right. The tumor just showed you its drug-resistant biology before you put the patient through a massive, traumatic, probably futile surgery.
Precisely. But, chemo alone is sort of the old paradigm now. In the modern era, we have to talk about biomarkers. This is the biggest revolution in thoracic oncology, period.
Absolutely. You cannot have a responsible tumor board without the molecular profile. The days of just asking, is it squamous or adeno, are totally over.
Biomarkers are mandatory. We need to know EGFR mutations, ALK rearrangements, and PD-L1 expression upfront for early-stage disease.
Because historically, we only cared about those for stage 5E patients to figure out which targeted pill to give them.
Yeah.
Now it dictates the entire curative sequence.
It really does.
Yeah.
Let's look at standard lung cancer first. No EGFR, no ALK. The standard of care was completely upended by the Checkmate 816 trial.
And I don't want to just rattle off a pharmaceutical catalog, but the mechanism here is crucial. Checkmate 816 didn't just give chemo before surgery. It added immunotherapy nivolumab.
And the mechanism is just fascinating. Because immunotherapy doesn't kill cancer cells directly, right? Cancer cells wear this protein disguise, PD-L1, that tells the immune system's T cells, hey, I'm a normal cell, leave me alone.
Like an invisibility cloak.
Exactly. And nivolumab just strips that cloak away so the immune system can attack. But why give it before surgery? Because to train that army of T cells, you need a ton of target practice.
Right. The primary tumor and the lymph nodes are a huge reservoir of tumor antigens.
Yes. So if you leave the tumor in, give the immunotherapy, and let the T cells swarm it, they learn exactly what the enemy looks like. Then you cut the main tumor out, and you still have millions of highly trained T cells patrolling the bloodstream hunting rogue cells.
Whereas if you cut the tumor out first, you throw away the training ground.
Exactly. And the results of Checkmate 816 proved it brilliantly. The median event-free survival was 31.6 months with the combo, compared to 20.8 with chemo alone.
But the really jaw-dropping stat was the pathologic complete response rate, the PCR.
The holy grail.
Yeah, meaning the surgeon removes the lobe, the pathologist slices it up, and they can't find a single living cancer cell.
Right. With chemo alone, the PCR was a dismal 2.2%. With immunotherapy added, it rocketed to 24%.
Almost 1 in 4 patients had their cancer totally wiped out before the scalpel even touched them.
And it didn't increase surgical complications either, but, we always have to read the fine print. You can't just blindly quote 24% for every patient.
Right, because Checkmate 816 explicitly excluded patients with EGFR mutations or ALK rearrangements.
Exactly. Those mutations create a cold tumor environment. Immunotherapy usually doesn't work well against them, and combining immunotherapy with targeted drugs later can cause severe, life-threatening pneumonitis.
Which is why the molecular testing is mandatory before you pick a drug.
Right. If they have an EGFR mutation, the pathway shifts. You do surgery, then look at the ADAR trial, which showed massive survival benefits giving a daily pill, osimertinib, for 3 years post-op.
And if they have an ALK rearrangement, the ALENA trial says use agevonelectinib, high PD-L1. And PowerDuo supports adjuvant atezolizumab. You just have to tailor the weapon. Okay, let me throw a wrench into this because this happens in clinic all the time. Let's go back to our patient. No EGFR, no ALK. They get the Checkmate 816 regimen, flawless lobectomy. A week later, pathology shows a PCR. 0 cancer left.
A great day in clinic.
The best. The patient is ecstatic. So can we tell them you're cured? Let's cancel the rest of your post-op targeted therapies, cancel any radiation talk, and dial back the scans?
It is so tempting, but the answer is absolutely not.
Not at all.
No. Achieving a PCR is an amazing prognostic indicator. It means the visible disease was super sensitive. But PCR is just a surrogate endpoint. It is not a guarantee of a cure.
It doesn't mean the microscopic cells hiding in the brain are perfectly eradicated.
Right. And it doesn't rewrite the trial rules. The patients in those trials who did great still finished the whole protocol. A PCR doesn't grant us permission to spontaneously drop the post-op regimen, ignore high-risk features for radiation, or relax our surveillance.
Like cancer can still come back.
It absolutely can.
All right, so we established the CORE, we locked in systemic therapy, surgery is happening. Now the big question for the rad-ons listening, where does radiation actually fit before the surgery?
For standard resectable N2 disease like our patient, the modern answer is it rarely fits before surgery.
Right.
The clearest role for planned, deliberate pre-op radiation, so trimodality therapy, is in highly selected, locally invasive tumors, specifically superior sulcus or Pancoast tumors.
Let's explain Pancoast tumors real quick because the anatomy dictates the radiation. They grow at the extreme apex, the very top of the lung, and because they're at the top, they immediately crash into critical structures.
Yeah, they invade the ribs, the spine, the subclavian vessels, and the brachial plexus, the nerve bundle for the arm.
Which is a surgical nightmare.
A total nightmare. If a surgeon tries to cut that out up front, they're almost guaranteed to leave microscopic cancer behind an R1 or R2 resection. So for decades, the standard has been concurrent chemo and radiation first.
Right, to sterilize the outer margins where it's creeping into the nerves.
Exactly. It pulls the tumor back from the brink.
Yeah.
Then when the surgeon goes in, they are cutting through sterilized tissue, which massively increases the chance of a clean R0 margin.
But back to our patient. We don't have a Pancoast tumor. We have a standard lung tumor with a confirmed N2 mediastinal node. So why not apply that same logic? Why not blast the mediastinal node with radiation before cutting it out, just be sure?
Because of the profound toxicity of forcing trimodality in N2 disease. When you stack high-dose chemo, high-dose radiation, and a major thoracic surgery, the human body just starts breaking down.
The randomized evidence is really sobering here, like the Espatu trial.
Right. Espatu took resectable stage 3 patients and gave them induction chemoradiation. Then, if they were still resectable, they randomized them. go to surgery or abandon surgery and just finish with definitive chemoradiation.
And it was a massive wake-up call.
It really was, because it showed excellent outcomes in both arms, but it did not establish an overall survival winner for the surgical arm.
The patients who just got definitive chemoradiation lived just as long as the ones who went through the massive trauma of surgery.
Exactly. Trimodality didn't buy them more time, it just exposed them to different risks.
But if we're talking about risk, we have to talk about the trial that literally haunts the dreams of thoracic oncologists. Intergroup 0139.
Oh man, 0139.
Yeah. If you're learning lung cancer management, this trial defines the boundaries of safety. What did it actually do?
So Intergroup 0139 took N2 patients and randomized them up front. Half got definitive chemoradiation to 61 Gray. The other half got induction chemoradiation to 45 Gray, followed by a surgical resection.
Okay. And if you look strictly at cancer control in the chest, the surgical arm won, right?
They did. Trimodality significantly improved local control and progression-free survival. The surgery kept the cancer from growing back in the chest much better than radiation alone.
So logically, you'd expect a massive survival advantage for the surgical arm. But the overall survival curve is just flat. The lines are right on top of each other. How is that mechanically possible?
The pneumonectomies.
Ah,
Yeah, the investigators dug into the data and found this horrifying divergence based on the type of surgery. The patients in the trimodality arm who only needed a lobectomy actually did quite well. They got a real survival benefit. But the patients who required a pneumonectomy...
they suffered catastrophic perioperative mortality.
Exactly, especially the right-sided pneumonectomies.
Let's explain the physiology of why that was so lethal, because it's fascinating and terrifying.
So when you deliver 45 Gray to the center of the chest, you cause profound microscopic damage. Blood vessels get fragile, airways get inflamed, healing capacity just plummets. Then the surgeon removes the entire right lung. They have to sever the right main bronchus and staple it shut. But because that tissue was irradiated, the blood supply to that stump is terrible. It doesn't heal.
Which leads to a bronchial stump dehiscence.
Exactly. The staple line literally blows open, spilling airway bacteria directly into the empty chest cavity, causing a massive, often fatal infection.
And the cardiovascular changes are just as brutal, because the right lung holds about 55% of your total lung volume.
Right, and when you remove it, the right ventricle of the heart still has to pump the exact same amount of blood, but now it's forcing it all through just the left lung.
The pressure skyrockets.
It does. And if that left lung got some scatter radiation dose, you trigger acute respiratory distress syndrome, ARDS. The patients in 0139 who had right pneumonectomies after radiation literally drowned in their own fluids or died of sepsis.
The deaths from the surgery completely erased the oncologic benefit of better local control. The cure was deadlier than the disease.
It's the most sobering realization in our field.
Which gives us our absolute non-negotiable safety rule. You never, ever casually pair induction chemoradiation with an anticipated pneumonectomy.
Never.
If our patient needed a pneumonectomy instead of a lobectomy, you strongly favor definitive chemoradiation. You do not risk that extended irradiated resection.
And this really requires foresight from the rat. If the team says, let's do pre-op radiation, you have to ask, what happens if the surgery gets canceled?
Right, because if you give 45 Gray and then the patient gets an infection and the surgeon cancels, you're in limbo.
You haven't given a curative dose, but you've burned through normal tissue tolerance. Trying to safely boost a paused plan to 60 Gray is incredibly dangerous. And you've used up your spinal cord and heart tolerance. If the tumor comes back in 2 years, you have no weapons left to salvage them.
Which perfectly transitions us to the postoperative reality.
Mm-hmm.
Let's assume the best for our patient. They skipped pre-op radiation. They got neoadjuvant chemoimmunotherapy, had a beautiful lobectomy, recovering well. Are we out of a job?
Not at all, because surgery creates a brand new data set.
The operative node and the final pathology report.
Yes, they become our absolute truth. The clinical stage we debated so fiercely is totally irrelevant now. We only care about the pathologic stage.
Right. Exact tumor size, exact number of nodes, extracapsular extension, and margins.
Oh, the margins.
Can I just air a massive pet peeve here?
Please do.
I lose my mind when I read an operative note that says, the tumor was peeled off the aorta, the margin was close, it looked a bit concerning, but I think I got it all. What does concerning mean?
I know, it's maddening.
As an oncologist trying to design radiation field, I can't plug concerning into an algorithm. I need objective categories, R0, 1, or R2.
Your frustration is entirely justified. Those categories dictate life and death. Let's define them. When the surgeon removes a lobe, the pathologist paints the cut edges with special ink, then slices it. An R0 resection means there is a clear buffer of normal tissue between the cancer and the ink.
Margin is negative.
Exactly. An R1 resection means microscopic residual tumor. The surgeon thought they got it all, but under the microscope, the cancer cells extend all the way into the ink. They slice through live tumor.
And R2 means gross residual tumor.
Right. They knew they were leaving cancer behind. Maybe it invaded the spine and they had to stop cutting to save the patient's life.
Now, the difference between R0 and R1 completely changes the trajectory. If the path report comes back R1, the first step is not to immediately order radiation.
Right. The first step is you pick up the phone, call the surgeon, and ask, can you go back in and do a re-resection?
Yes. If it's feasible to reopen the chest and get an R0 margin, surgical clearance is the best chance for survival.
But if they can't, if taking more tissue means cutting a major vessel, then post-op radiation or chemoradiation becomes an urgent necessity. You cannot just observe microscopic disease.
And if it's R2, persistent gross disease, you basically have to build a full, high-dose definitive plan around that tumor while navigating a freshly healing surgical bed.
It's extremely tough. But let's look at the scenario that caused the biggest earthquake in thoracic oncology recently, the R0-PN2 dilemma.
Okay, let's say our patient's path report comes back. Margins are beautifully clear, R0. But the pathologist confirms there is still viable N2 disease in the mediastinal nodes. The drugs didn't clear it all.
Historically, for decades, that was an automatic reflex. If you had resected pathologic N2 disease, the radonic delivered port post-operative radiation therapy. We'd blast the whole mediastinum with 50 to 54 gray to sterilize the bed.
Based on older data showing it improved local control.
Right.
But the evidence shifted violently with two huge randomized trials. Lung Art from Europe and PORT-TC from China. They asked if routine port actually helps modern R0-PN2 patients.
And the answer shocked everyone. Both trials found that port did exactly what it was mechanically designed to do. It significantly improved mediastinal control.
It stopped the cancer coming back in the chest.
Yes. But neither trial showed a routine disease-free survival or overall survival benefit for the whole population.
Which is the ultimate radiation paradox. How do you prevent the cancer from coming back locally, but fail to extend the patient's life?
Toxicity.
Yeah.
The control arm surgery without radiation had much better local control than historical controls anyway, thanks to better surgery and systemic therapy. But when you added radiation in the port arm, you caused massive collateral damage.
Lung Art reported way more serious cardiopulmonary events.
Because the beam has to pass through the heart and healthy lung. Over time, that causes microvascular damage to the heart muscle, accelerates coronary artery disease, causes pulmonary fibrosis.
The patients weren't dying of local cancer recurrence. They were dying years later of heart attacks and respiratory decline from the radiation.
Exactly. The cure eroded their lifespan. But we have to interpret this correctly. The conclusion of Lung Art is not post-op radiation never helps anyone, ever.
Right. The nuanced conclusion is routine automatic port for every single R0-PN2 patient is no longer standard of care. We can't treat PN2 as a monolithic trigger anymore.
Exactly. We shift from reflex to intense personalized selection. You have to be a forensic pathologist. Look at the nodal burden. Was it one tiny microscopic focus? Or 5 massive, bulky nodes the surgeon barely scraped out?
And look for extracapsular extension, ECE.
Right. If the cancer is bursting through the lymph node capsule into the mediastinal fat, the local recurrence risk skyrockets. The argument for port gets way stronger.
But you still have to balance that against the mechanical cost. You look at their baseline cardiac risk and lung reserve. If covering a bulky nodal bed means giving toxic doses to the heart and the only remaining lung.
The theoretical local benefit gets erased by lethal toxicity. You just don't ruin a good surgical outcome with an unnecessary toxic radiation plan.
Which bridges us perfectly to the long game. Survivorship, toxicity, and surveillance. We can't just think about the next 6 months. We have to think about the next 10 years.
We have to consider the cumulative physiological burden.
Yeah, going back to preserving the battlefield, toxicity isn't just the radiation beam. The patient has taken a cumulative hit. They lost 20 to 30% of their lung volume from the lobectomy.
Their bone marrow is suppressed. Peripheral nerves might be damaged from the platinum chemo.
They might have smoldering pneumonitis from the immunotherapy. If we arrogantly add 54 gray on top of that just to feel better about local control, we might push them off a physiological cliff.
It's a razor-thin balance, and that burden really dictates how we follow them once active treatment is over. Surveillance is critical.
What's the standard framework now?
Rigorous history and physical, plus a diagnostic chest CT with contrast every 6 months for the first 2 to 3 years. After that, if they're cancer-free, annual low-dose chest CT for the rest of their lives because they're at risk for a second primary lung cancer.
Notice what is explicitly missing there. PE scans.
Yes, patients constantly ask for PT scans.
They think it's the ultimate full-body metal detector.
Right. But using PET-avid for routine, asymptomatic surveillance in a post-treatment chest is just a recipe for clinical anxiety. The false positive rate is massive.
Because the surgical bed is full of scar tissue.
And the radiation field causes inflammatory scarring that lights up violently on a PE for months, even years. If you rely on routine PEs, you'll be chasing glowing shadows, doing risky biopsies on scar tissue, and just terrifying the patient.
We use diagnostic CTs to look for structural growth. We only reserve PT scans for troubleshooting, like clarifying a new concerning nodule on the CT.
And even then, the ironclad rule applies. Pursue tissue confirmation before a major salvage decision. You biopsy the recurrence.
And the word salvage brings us right back to our core theme, preserving the battlefield. Let's say our patient did not receive elective port. We omitted radiation and just observed them. 2 years later, the CT shows an isolated recurrence in a single mediastinal node.
Okay.
Because we held our fire initially, that patient retains a highly powerful curative intent salvage option. We can treat that recurrence with definitive high-dose chemoradiation.
And this is arguably the most vital strategic element for listeners to grasp. Avoiding unnecessary port in a clean case doesn't just spare the heart today, it preserves your ultimate weapon for the future.
Because if you panic and shoot your shot with port right after surgery when it wasn't strictly necessary, you permanently alter the tissue.
The spinal cord remembers every dose. The heart remembers every dose. If they get a recurrence 2 years later directly inside that old port field, your options are terrible.
Right. Trying to re-irradiate the mediastinum to a definitive dose can cause esophageal necrosis or catastrophic bleeding.
By having the discipline to omit port when the data says so, you are literally preserving a lifeline for the future.
The sequence you choose on day 1 dictates every single move on the chessboard for the rest of their life.
It's a 3-dimensional chess game played over years.
All right, we have covered immense ground today. We dismantled AJCC9, ripped apart the illusion of resectability, explored Checkmate 816, and navigated the pitfalls of 0139 and lung art. Now it's time for the board blitz.
Let's do
A rapid-fire review of 3 testable decision points. If you're listening, actively challenge yourself to answer before we break it down. Scenario 1, the trap of PFTs.
Okay.
Patient has biopsy-proven non-small cell lung cancer. Excellent PFTs. They run 3 miles a day. The PT shows one severely FDG-avid ipsilateral mediastinal node. It has not been biopsied. The surgeon says, fit and operable, let's schedule the lobectomy. Are we ready for surgery?
Absolutely not. We are nowhere near ready. This illustrates the danger of conflating the CORE mnemonic. Medical operability, the good PFTs, just tells us they won't die from anesthesia. It does not establish the true pathologic diagnosis of that glowing node.
Or the anatomic resectability.
Right. Proceeding directly to surgery is a catastrophic error because if that node is malignant, it immediately redirects the entire sequence to neoadjuvant chemoimmunotherapy or definitive chemoradiation. You must pathologically confirm the node with an EBUS.
Spot on. Never confuse a physiological green light with an anatomical green light. Scenario 2. The single-station N2.
Yeah.
The pulmonologist does the EBUS. Pathology confirms a malignant single-station non-bulky N2 node. Molecular panel shows no EGFR or ALK. Brain MRI is clear. Patient is highly fit, and surgeon confirms a margin-negative lobectomy is technically straightforward. How should the team frame the primary treatment recommendation?
The most evidence-backed framing is to present neoadjuvant chemoimmunotherapy based on Checkmate 816 followed by a planned lobectomy. But, and this is critical, you must also explicitly discuss definitive chemoradiation as a perfectly valid curative alternative.
The key is avoiding a forced, rigid trimodality pathway.
Exactly. Don't jump straight to surgery without systemic therapy, but also don't force pre-op radiation, especially given ASPATU and 0139. You present complete, safe pathways.
Excellent. Scenario 3, the positive margin. Patient completes induction chemoimmunotherapy, undergoes a planned lobectomy. A week later, pathology shows an R1 bronchial margin, microscopic disease left behind. What is the absolute immediate next step?
The immediate next step is not writing a radiation prescription. You get the thoracic surgeon and pathologist on the phone. You ask the surgeon, is a re-resection technically and physiologically feasible? Can we safely clear this margin without catastrophic morbidity?
If yes, Prioritize surgical clearance.
Right. But if the surgeon says it's impossible, then, and only then, do you pivot aggressively to post-op radiation or chemoradiation. An R1 margin is viable cancer. You don't observe it, and you don't reflexively radiate without asking if a surgical fix is possible first.
Exactly. Surgery and radiation have to coordinate the rescue.
As we close today, I want to leave you with one final thought, the phrase we kept returning to, preserving the battlefield. The sequence you choose on day 1 fundamentally shapes every option on day 1,000.
A pneumonectomy permanently changes the meaning of every future radiation dose.
Right. And having the discipline to omit unproven radiation today might save their life by leaving a viable salvage option tomorrow. Treating thoracic oncology isn't just throwing every weapon at the disease instantly. It's about strategic restraint, preserving the battlefield so the patient can actually survive the war.
Get show notes and complete practice oral boards at redonsmartlearn.com and subscribe for our next episode. Thanks for tuning in.